So we're still not in stomach, right? Or
I
are we?
was, yeah, I was there. I just came
Okay.
back.
Okay. Show me the stomach. Good. Now you know. Are we?
Mustafa, we can hear you, but just we can't see you. We're trying to get to that.
Okay.
Well, now we can see you as well.
Okay. Keep. Just
Okay,
make
we
sure
need
you're nice in the stomach. Okay. Now you know in the stomach. So first thing you do is just suction out the
EUS
stomach.
और वो image to जरा दिखा दें.
You can see the endo image or no? Oh,
Just
not yet.
1 second.
Okay, we're just emptying the stomach. So big wheel towards you.
Yeah, we can see the EUS image.
Pull the scope a bit. So you can see here. Pull back the scope.
And endoscopic.
Suction. So we're just getting rid of all the fluid in the stomach to begin with. Okay. So now that we're here, again, first step is to evaluate the, look for the liver, right? So you're going to, that's it, big move towards you a bit, and then just go clockwise. Good. There's the liver coming into you. Keep coming. Keep going. Keep going. Keep going. Don't push in. Pull back a bit, and keep going clockwise.
Don't see the EUS image.
Okay. Okay.
Can we have both EUS and endoscopic
suction
or
a bit
no?
more. And if you can't suction it, then put the balloon up a bit. And big wheel towards you a bit more. Big wheel towards you.
Yeah.
Okay, good. Now keep going clockwise. Keep going clockwise. Keep going. Keep going. That's obviously keep going clockwise. You're going to keep going till you lose the liver and you find the aorta. So keep going.
Mustafa, do you think image is getting better or no?
This is not optimized, but it's just,
So
it's too dark. That's the aorta. So keep going. That's the, so now you also need to start recognizing structure. So this is your crest of the diaphragm, and you're starting to see the adrenal gland.
Yeah.
So if you keep going clockwise, keep going, keep going, keep going. Don't move the scope. So there you go. Keep the adrenal in view. And that's the adrenal. Keep going. Since you saw it, you keep going, and you'll see a bit of the kidney, right?
Yeah.
Now you can just go slightly counterclockwise, and you should see the celiac around here as you keep going counterclockwise. It should come off here. So you may have to push forward a bit. Good. And now go counterclockwise. Keep going counterclockwise. Keep going. Keep going. So you may have to do big wheel slightly towards you, and you'll see the celiac take off. So push forward a bit because you're losing it. So keep advancing. Now sometimes you get hung up at the G-junction. Right there is your celiac, right?
Yeah.
So now you have your celiac in view, so you can follow the celiac. So you have to maintain that view. Now you're going to maintain that view of the celiac and advance the scope a tiny bit to follow it upwards like this. And now relax your big wheel a tiny bit to see if you can continue to follow it forwards. Keep spinning. Is this the same thing as that? Right there, you see that's the splenic artery. So now you keep following these, keep following. And there's, actually that was hepatic and that's splenic. So, and there's your pancreatic duct coming into view. So keep following it forwards, relax your big wheel, and they'll drop the pancreas down this way. And now, but don't lose the artery. So relax it, so find the artery again. Okay, now relax your big wheel here. If that doesn't work, go clockwise. Because you have to figure out what maneuver allows me to get this guy into view. You want this PD into view. So there you go.
I can do that, yeah.
Okay, there you go. Now you advance. So now, so that's your pancreas. You just saw it dip towards the tail.
Yeah.
So if you go forward a tiny bit and go counterclockwise. Keep going counterclockwise. So from here, go counter. And big wheel slightly towards you. Big wheel slightly towards you and go counter, and you'll start following the pancreatic duct towards the tail. So go counter, keep going counter, keep going. Keep dropping that left hand and relax the big wheel because it's going away from you, right? So relax. Keep going counter. Keep going. Okay. Now just Yeah, we're not really moving much here, so you have to like just relax. Big wheel towards you a bit. Big wheel towards you. Relax your big
Yeah.
wheel. We just need to get this to go to the left there. There you go. Keep going to the left. Keep going. Keep going. And now you're getting the PD coming towards the body. Keep going counterclockwise. There you go. Keep going counterclockwise. And now that's your pancreas in view, right? That's your splenic artery, splenic vein.
Yeah.
So good. Keep going counterclockwise. That's it. Now you have that view that we normally look for.
Yeah.
So keep going. Since you've seen the tail side, now you're in the mid body. There's your duct. Where is it?
Is it free?
But yeah, there you go. But this is your pancreatic duct. So you're going to follow it to the left there. Okay. So go ahead. Keep going leftwards. Keep going counterclockwise. There you go. Keep going. Keep going. Keep going. And now it's going slightly. So you may have to do slight big wheel towards you to bring it closer to the probe, and keep going counterclockwise. There you go. Keep going, and that's the pancreas. Now the duct is dipping down this way, so pull back a tiny bit and go. There you go. Now that's the PD going towards the neck head area. Okay, so that's basically your pancreatic duct evaluation. Go clockwise for a second, just to make sure we're not looking at it. Yeah, that's going to be the SMV, so that's the PD is going to be actually follow down this way too. So that's pretty much it from here. Okay, but now what I want you to do is try and do all this a bit faster. So you just relax like this, go like this, follow it. So again, it's this left shoulder. I know it's like repetitive, but this is the movement you want to see. You can see, you can, in this one sweep, we're finding the, and I'm not doing much big wheel either, but we're following the PD going. So this is what you want to do, okay? This is not very bent. The tendency early on is to do this. So just keep this straight and just do this. And then we'll have to go to the bulk so you get to do more than one station. So push forward a bit because your pancreas is off. Okay, good. And yeah, relax this. And this should be the one doing all the work. There you go. And push forward a bit. There. From here, down and see that?
Yeah.
So try that. Just push forward because you're losing it. So push forward. There you go. That's good. And go, yeah. See that brisk movement?
I get it. You want me to keep it to the pancreas.
The pancreas, exactly.
Yeah.
That's the idea. You follow the pancreatic duct, right? Because that's what our organ of interest is primarily here.
So that's your
But if you have
pancreatic
lymph
duct.
nodes, you're looking for, yeah, there you go. It's nicely dipping down towards the tail. Okay, good. Let's go to the bulb because we have a timer. I want you to see the bulb station too. So yeah, look endoscopically. Good. Keep advancing.
Mr. Bhai, we can't see the endoscopic image. Can we have both EUS and endoscopic image?
Yeah. They're working on it. Good. So now we're in bulb and push forward a tiny bit. Good. So right away you saw this is your,
So that's the
what is this?
that's the portal vein.
Good.
Yeah.
So now that you have the portal vein, you know that bile duct should be close by. And I don't know if this guy or not, so we're just going to put, but no, it's an artery, so it's a vessel. So keep the portal vein in view.
Can we show the EUS
Good.
image
And
now, please?
go, usually in this situation, I will go counterclockwise. I will push the scope forward, drop my left hand, maintain the view,
Thank
so
you.
relax the big wheel, and I'll try and follow my vein to the liver. So you see if you can do that. And keep going. Push, advance in more. Right. Okay. So this here,
That's your
what is this?
That's a stent in the CBD.
Yeah, I don't see the stent right here, but that is the CBD. There is your stent right there with those bright
So there is a lot of
parallel walls.
Yeah,
Yeah, there's a lot of artifact. And the wall thickening here,
thickening is there. Yeah.
and that parallel bright walls are obviously the stent. So you just, once you find the portal, usually you have to push forward, relax your big wheel, and that'll take you towards the bile duct. Now if you go counterclockwise, you'll go towards the liver and maintain this structure, which is your bile duct. So if you lose it, then you have to go back to it and do something different. So relax your big wheel and go counter. Also, you have to keep in mind, what is the purpose of this exam? It's really your ampullary lesion, right?
Yeah.
So you can do this, and there you go. Now you're going towards liver. There's some debris in there, I think, too, like some sludge. But honestly, we don't want to waste too much time on this because you want to try and see what's going on at the bottom of the duct. So now start going clockwise. Now as you go clockwise, it'll fall away from you. So you have to big wheel towards you. So you have to anticipate that. So go clockwise, and it's going to go down to the right. So you have to do big wheel towards you and keep going clockwise. That's it, keep going. There's a lot of artifact going on here. So we're losing our view, right? So push forward, there you go. Okay, there it is again. So we're just not maintaining the probe has to be up against the duodenal wall for you to follow it. Right? If you're not up against the wall, you won't see anything, you'll lose your view. So there, and now go, there's your bile duct lumen. Now go clockwise. Big wheel towards you to bring it closer. Suction. Section, section, section. You can try and put the balloon up here because you see that air in the lumen. Are you sitting on the air or no?
No, I'm not.
Okay,
I
good.
just press the balloon now.
Okay, good. And that's enough. That's a lot of balloon. Okay, good. Now suction and go clockwise. And it's gonna, so you have to push forward to try and maintain it. And it's going off to the right here. So see if you can follow it down to the right. Sometimes you can't. So big wheel towards you. There you go. Good. Keep going clockwise. Keep going clockwise. Keep going clockwise. And maintain that view. So yeah, there you go. Good. Keep going down. Big wheel towards you. Sometimes you just, you
just
reach
lose
a
it,
limit. So you may have to push your scope forward like this.
I did, but
Sometimes,
actually I lose it.
yes, just keep chasing it, right? And now big wheel towards you. There you go. So you have to just chase it. If it's falling away from you, you just have to keep going after it. So keep going clockwise, and you're gonna reach the duodenal lumen here very soon. That's gonna be air in the duodenum. So keep going clockwise. Push scope forward more, and big wheel towards you, and go counter now because you lost it. This, by the way, looks like a lesion, right?
Yeah.
So we're starting to see something that is concerning. But now go counter for a second. But that could be the stent in there. Go counterclockwise. Keep going counter. It's okay, keep going counter. Keep going counter. Keep going, keep going. There's your bile duct again. Keep going. Keep going counter. Big wheel towards you. Keep going toward counter. And big wheel towards you. Bring it close to you. Big wheel towards you. Push forward. So yeah, this is a constant, like, it's like a back and forth between you and the duodenal wall to see how you can maintain that stent. So there's a lot of small movements in the bulb area, okay? But again, for interest of time, we're going to go now to the second portion. But that's how you, like, basically find your lesion and then keep a view endoscopic. Your balloon's pretty big up. So in tight situations, a bit of balloon will actually help you. It's a cushion with which you can basically advance your scope. So now we may end up putting the balloon down a bit, but there you go, you can reduce. Good. Now see if there's a luminal lesion. I assume they didn't see a luminal lesion when they did the ERCP, but usually just I would pull back here to look to see if there is anything that you can see, because if you can, then you can just do forceps biopsy. So keep pulling back, and you'll start seeing the stent in a minute. So that's the area of the papilla. Keep pulling back a bit. there's the stent, and nothing really, but I can't tell with this view if it's ulcerated or not, because it's also had a sphincterotomy, but there's some fullness here. So if you're not sure, now what I do, basically good, you already did that, so turn clockwise, good, and now you're like, good, the mesenteric vessels, big one towards you. I usually will bend this down for stability, so no, just straight down, like this. And there you see lymph nodes already, right? So these are peripancreatic aortocaval lymph nodes. Now you're going to pull back. We can sample these too, because I think that's what they reported on the imaging too. So now go clockwise towards uncinate and pull back some. Good. Keep pulling back. Keep going clockwise for a second. So we're not really going clockwise. Good. Okay. There. Because you're the aorta, see, so you want to go clockwise. So a lot of tension here. What I would spin counter, PD, ballot, and go clockwise. So I do a lot of this with my, like this.
That's the pancreas.
Yeah, that's the pancreatic duct, and there's your stent in the bile duct.
Yeah.
Okay, good. So where was that area of abnormality? So keep, because we saw this big mass lesion. Maybe it was a lymph node. So keep, now maybe it's in the uncinate, so keep going clockwise here. Keep going nothing. Okay, pull back. Maybe they were the lymph nodes that we saw. So here you're at the, you can see the stent entering right there. The stent is entering the duodenal wall. So we're not seeing an obvious lesion here, but you may just need to pull back a tiny bit more. Good, keep pulling back. And just go spin around, clockwise, counterclockwise. See if you see anything. More. Your range of motion needs to be a bit more. The PD, nothing really there. Go the other way now. And now pull back the scope a bit more. You can tell from your vessels if you've made progress or not, right? If you've pulled enough or not really. So pull back, keep pulling back a bit more. Bring the PD down to 6 o'clock. Good, keep pulling back, relax your big wheel a bit. So keep pulling back and spin around. Go the other way. Go more, it's okay, go more. You do get unstable, but okay, stop there, now go the other way. Back towards the PD, so go clockwise. And pull back more. Bring that pancreatic duct down here. Relax the big wheel a tiny bit. Okay, now go counter, find that duct. There, okay, good. Good, keep pulling back a bit. Just there you go. It's okay to pull back a bit, right? Now go clockwise. There's the bile duct. I'm not seeing anything. We may, right there, big wheel towards you. I don't know if there's a lesion here or not. I can't tell. So let me take over because of time purposes, but that's the idea. You did good. Also, I think what the view that we saw it best from was the bulb. So I might try that. So there's my bile duct, following it down. There's the pancreatic duct. Lymph nodes. I'm not seeing a definitive lesion here. Just there was one view that you had where I thought there was something.
That was from
The
gap.
bulb,
Yeah.
yeah. But right now with both these views, I have not seen anything. The only thing I can think of is we could potentially sample the lymph nodes. These guys here. But even these may be reactionary because they're irregular and not super hypoechoic. So I don't know if you're with me or not, but I don't see any definitive mass. I see these lymph nodes, and I may just sample the lymph nodes. So I don't see a pancreatic lesion.
There's a lot of heterogeneity in the pancreatic.
Yeah, I think this post-CRCP as well, there are changes. These definitely don't look very concerning to me. Where was the mass? I'm not sure. I mean, unless we do, I think forceps biopsies of this. थोड़ा सा पानी दिखाएगा 62. थोड़ा सा There's a lot of sludge coming out of the bile duct. And we did ampullary biopsies before. Because right here the PD looks normal, the bile duct just has that stent and sludge. To the left of it, I don't see much here. This looks pretty bright, not obviously hypoechoic. There's right there, there's a bit of a hypoechoic region, right there. Which may or may not be. So we can get a needle here and biopsy this. But it's small. I don't know if this is like truly lesional or not. Needle Dylan, 11.5 by 7. But this is like the most abnormal looking thing we've seen.
There's a lot of thickening of the CBD as well.
Yeah, but that's post procedure, so I think that. But this looks inside. So we can. Not that I can make out with a stand. That's a good question, but I don't know if right there it's traversing the intraductal component. So I think we want to target this area. So that clearly looks deeper than like the muscular. This is the MP. So what is this rounded area?
Mustafa, we are going to swap over to the
Yeah,
next room.
no problem.
Okay, thank you.
It's right close to the bile duct. But if these biopsies come back negative, I would do ampullary biopsy. We can see if we can get some right now. careful. The soft things will bounce off, so you have to go firmer at them.
Standing है. So meaning by कि possibly it's inflammatory and not malignant. लेकिन जब भी टिश्यू होगी तो हाइपोइकोइक होगी. लो अब ये तीनों चीज़ें जिस तरह मैंने आपको बताई हैं, पैंक्रियाटिक डक्ट, सीबीडी और पोर्टल वेन, दोबारा करके दिखाओ मुझे.
Dr. Yas, we have joined your room now. Can you hear me? Dr. Yas, can you hear us?
Yes, we can hear
Yes,
you.
excellent. We've just joined your room.
Okay, right, thank you. So Dr. Mushtaq Safi is basically trying to show us portal vein followed by pancreatic duct and then common bile duct. So we are at the D1 at the moment. He needs to come back and introduce the endoscope again. So whenever a person is lost, especially at the training stage, he needs to come back and start all over again at that station. I'm suggesting to the beginners that at least 50-60 cases, just like clinical methods in third year, that we are not worried about pathologies. Pathologies are out of course for them at the moment. So for the first 50 or 60 cases, they need to concentrate on the methods. And method is maneuvering of the endoscope at different stations. Identifying the normal structures, identifying, for example, in this case, portal vein, and in the portal vein, SMV and splenic vein. Once he has identified splenic vein and mesenteric vein and portal vein, it will be easier for him to jump to the pancreas and pancreatic duct, and from pancreatic duct to the common bile duct. So Dr. Mushtaq is supposed to show me portal vein. Okay, this gallbladder, you've gone, if you've seen the gallbladder, that means that you've gone a bit too far inside. So you need to come back, and with a long scope you need to go back in. Okay, fine, we can see the portal vein. But it will be best that you come back and start all over again. Yes, good. So suction, and the way I'd shown you the portal vein and no, probably you've gone too far in. Right. Okay. थोड़ा सा वापस आके दोबारा जाओ, वापस out in the stomach and then go back in. You need to identify the portal vein. Portal vein with the confluence, yes, very good. Now try to identify the portal vein, right? Where's the portal vein? Okay, good. Now, you need to clarify these confluence. So big wheel slightly away from you now. Once you have seen the portal vein, concentrate on that portal vein. अभी आप random structuring पे जा रहे हैं. So random structuring में EUS में once you go into the random structuring, that means that you have lost yourself. तो portal vein कहाँ पे? वापस जाओ portal vein पे. Okay, fine. Try to bring that portal vein underneath your. Okay, good. Okay. Now you see, here is mesenteric. नहीं है, देखो आपने देख लिया ना, तो उसको हिलने ना दो, उसको अच्छा evaluation करना है. Big wheel slightly away from you, slight rotation to the right, slight rotation to the left. Now you see you're getting a better view. Yeah, again a better view. Now here you have mesenteric. On top of mesenteric, it's all pancreas. Here it is splenic vein. This is confluence, and then this is portal vein. So big wheel slightly away from you, and that's how you bring the whole head of the pancreas right in front of you. Okay? Now, is this speedy? Definitely speedy. Now, is it dilated? Yes, it is dilated, most likely. So let's measure the PD. .3. Normally 3 to 1. So this is 4.3. Right. Now, you have seen the portal vein, you have seen the sphenomesenteric vein. You need to switch your attention to the pancreatic duct. Now, pancreatic duct under your transducer, go to the right, go to the left. Yes, very good, very good. Now, you're concentrating on the pancreatic duct now. So concentrate on the pancreatic duct alone. Forget about all the other ducts. So trace the pancreatic duct to the neck and trace the pancreatic duct towards the ampulla. On the top, we expect that you should be having CVD. So right here, that's what I was mentioning, that we have okay, this is the pancreatic, and you need to bring to a place where they are very close to each other. Okay, so big wheel slightly away from you and rotation. Okay, very good. That's what you're doing. Very good. Excellent. Try to bring it close to each other. Okay, and right here, if had there been a tumor, we would have expected a hypoechoic area at this particular place, and we don't see anything hypoechoic here, right? But from a different angle, we need to look. For example, for uncinate process, we need to go down into the distal duodenum and see it from there. Okay. Now trace the CVD up and trace the CVD down. Up means towards the hilum of the liver. Now bring the CVD underneath your transducer. Okay, bring it here. Now you have placed it securely. Big wheel slightly away from you. Keep it underneath your transducer. Maintain the suction. Now don't let it loose. हल्की सी जो jiggling movement है, and big wheel slightly away from you. Keep pushing, and that's how you are able to see right up to the hilum. ठीक है, slightly right, left, जिसमें आपको ऊपर जगह मिलती है. So you're basically seeing at the CVD from one end to the other without any difficulty, and you're able to see the conference as well right here. तो इसको कंसिडरेट करो कि यहाँ पे कुछ है जो जंक्शन आपका बना था ये. Do you see anything hypoechoic? Huh? Yeah. Do you see anything hypoechoic? No, it's more of hyperechoic. We don't see any hyperechoic. So possibly it's some inflammatory area, not the neoplastic, right? So slight right, left. इसको मज़ीद हमने क्लैरिफाई करना है, तो इसको ये नहीं, हाँ, ये जंक्शन आपका ना, वो जो चीज़ आप देख रहे हो उस पर कंसंट्रेट करो. ये ओके. सो कंटिन्यूसली हल्की सी millimeter wise right and left movement, and you're able to evaluate it in a much better way. ठीक है. Now CVD is coming from this side. Pancreatic duct is like this, meaning by that you are D1. अगर ये होगा ना आपका D2, तो CVD and pancreatic duct they will be like this, parallel to each other. तो अब हम इसको CVD को हम चाहेंगे कि उसके लिवर वाली साइड पे evaluate करें. So in order to do that, big wheel away from you, slight push, big wheels away from you and slight push. ठीक है. And concentrate on your eyes on the CVD. It should be going up. अब CVD नजर आनी चाहिए, उसका विजन से जाए ना. Okay, okay, okay. Good, 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 good. Excellent, excellent, excellent. हल्की सी jiggling movement. Push. देखो, we are going towards the heart of the liver, and there you have the division away from you. Big wheel away from you. Slight jiggling. और ये यहाँ पे आ गई आपकी right and left में common hepatic duct dividing into right and left. ठीक है. चले. Now we go to the D2. insufflate and push the endoscope down into the distal duodenum, just like ERCP. टाइम हो गया? टाइम तो नहीं हुआ?
साइमल्टेनियसली जब रूट चल रहे थे तो थोड़ा सा
हाँ,
स्पेस होता है इंसान
कोई बात नहीं। अच्छा यार तो सही था। अच्छा, डिस्टल duodenum में तो you need to pull back, ठीक है, pull back and place the transducer right on top of the papilla. अगर आप EOS पे जाओगे तो आपको किडनी, IVC, एओर्टा, ये तीन स्ट्रक्चर्स बैक टू बैक नजर आएंगी, किडनी, IVC, एओर्टा। वहाँ पे एंडोस्कोपिक इमेज पे look for the papilla and place the transducer right on top of the papilla. ठीक है, so identify the papilla. You can do either go EUS wise or you may go on the endoscopic image wise. ठीक है, you're going down and now you need to pull back. ठीक है, okay, fair enough, very good. Now you're way down into the duodenum. So now stop insufflating air, go to the suction. With right left movement, kidney is a big structure and this is the kidney that you have, right? This is the kidney that you have. Now once the kidney is there, that means that the first structure on the posterior side, on the right side, that's been identified. From kidney you need to jump to the IVC. So slight pull back, हल्का से जिग नहीं, अब बहुत ज़्यादा आपने पुल कर दिया and you're back into the stomach. देखो EUS में जो मूवमेंट्स हैं वो बहुत छोटी छोटी मूवमेंट्स होती हैं। तो आपने किडनी आइडेंटिफाई किया है तो किडनी के बाद जो अगली चीज़ हल्की मूवमेंट के साथ ऑन द मिडल साइड इज IVC. Then further towards the medial side you have the aorta. So go down into the distal duodenum, जैसे आप पिछली दफा गए थे। शाबाश, go down, go down. जैसे ERCP में नहीं जाते आप डिस्टल duodenum, एग्जैक्टली वही मैन्यूवर है, कोई डिफरेंट नहीं है उससे। एंडोस्कोप की इमेज आपको बड़ी तो नहीं चाहिए? हाँ ठीक है। जनरली आई पर्सनली गो विद द सेम इमेज, क्योंकि जिस पे आप अपने आप को ट्यून कर लोगे यू गोइंग टू लिव विद दैट फॉर रेस्ट ऑफ योर लाइफ. But there are many people who like to go with the bigger picture of the endoscope, but then it's entirely up to you. ठीक है, यहाँ से अगर आप pull back करोगे तो you will be going down into the distal duodenum. Okay, there you go. Right? Now take out all the air. हाँ, take suction. अब किडनी को आपने आइडेंटिफाई करना है. यहाँ पे किडनी आएगा आपके इस साइड पे, लेफ्ट साइड पे. ठीक, अनस्टेबल पोजीशन है, कोई बात नहीं. ठीक है, ओके. पुल बैक. ओके, नाउ वेरी गुड. ठीक है. Take out all the air. Try to identify the kidney on EUS image, or maybe with the endoscopic approach. अच्छा, you slip back very quickly. दिखाओ. अच्छा, जब बहुत सारे air है ना, तो this is going to give you a problem in terms of maintaining your position in the distal duodenum. So take out all the air. ये क्या हुआ? CO2 पे अच्छा अच्छा बस ठीक है फिर तो मसला ही कोई नहीं ओके गुड अच्छा यहाँ पे जैसे मैं है ना now my movements are very controlled I'm going to although I can see the kidney on left hand side and this is the IVC right here this is IVC ठीक है IVC आ गई जो baggy appearance है slight pull back further I need to see the aorta right aorta आ गई aorta is smart on right side ठीक है on right side I need to look at the pancreas and this is pancreas ठीक है जी तो दरमियान में आपकी ये ड्यूरल ल्यूमन है सो वाइट इज अनस्टेट प्रोसेस हल्का सा gradual subtle movement right and left and you should be able to see the things in a better way Achha, can you see we have something here
It's a 5.3.
but we are not sure what it is तो अभी इसको थोड़ा सा नहीं दिस नॉट लेंथ वी हैव समथिंग हियर पता नहीं क्या है कहना मुश्किल है उसमें जब तक आप क्लेरिफाई ना कर लो यू शुड नॉट बी जंपिंग टू द कंक्लूजन्स क्योंकि डक वहाँ पे जा ख़त्म होती नजर आए तो देन वील बी हैप्पी कि हाँ ठीक है या कोई और आपका पानी देना है एक स्ट्रिंग और दे दो फ्लूएंट सीसी तक का आमतौर पे दे दो अंदर पानी दे पानी से ये कि आपका ना it becomes easy for you to identify the structures on this side so it gives you an interface to play around एक और Right, I think now I'm comfortable. So once I have this thing on this side, ये आ गई aorta आपकी, ठीक है जी. Aorta to the left, and we have the lumen with the water inside. Things are getting easy for us, and we'll be able to visualize the pancreas in a better way, right? ठीक है. Actually, we have a small duodenum and we slip back into the stomach very quickly. So maybe an evaluation once again.
Dr. Yas, we will swap over the room.
I beg your pardon, say it
We're
again.
going to swap over the room. What are we at the moment? What stage
We are
are
trying
we
to
at?
go into the distal duodenum and have a better look at the CVD, CVD to, at the distal duodenum end, because we have been able to investigate the evaluate the CVD from the D1 very effectively, but we are not able to maintain our position in the distal duodenum. We are not able to go down into the distal duodenum comfortably. Patient has got a very small duodenum, so we fall back immediately. The moment we pull back, we fall back. I think that's the place where possibly the balloon has a role, but not generally otherwise not.
And What about the perihylum lymph nodes? I think that was the indication, was it?
Okay. ये aorta आ गई, aorta को अपने left side पे लेके गए, and on the right side we have started to see the pancreas. Okay, now this is the pancreatic duct, and we need to trace the pancreatic duct towards the ampulla. So slow release of the big vein, and tracing it to the point where it is becoming concurrent with the CVD. So that's the ampulla. So we see the CVD in the top. Yes. So as said, we don't see anything hypoechoic at the end of the two places. So as said, there's nothing like periimpulmonary CA. Possibly it's just an inflammatory stricture which is affecting the opening of the two ducts. So as said, I don't see anything abnormal to put the needle in and take the biopsy. Right? So we have the pancreatic duct and we have the CVD coming close to each other. Nothing excitingly abnormal. So except that the duct is dilated, prominent, both the pancreatic duct as well as CVD are prominent. We don't see anything obstructing the two ducts in the form of hypoechoic mass. And that's what we are interested in. This is the pancreatic duct going up. We have slipped. So conclusion is that we have an inflammatory stricture and we don't have anything hypoechoic towards the end of the pancreatic duct and CVD confluence, that's papilla. And on the look, papilla looks normal. So it's an inflammatory stricture and that needs to be managed with the help of ERCP. जी हाँ एग्जैक्टली ये बिल्कुल 3D prominent CVD and we don't see any hypoechoic lesion at the end of the two places. Thank you.